The screaming started at 2:47 a.m. I was in the break room, staring at cold coffee and trying to remember why I'd chosen medicine, when the sound cut through the quiet like a blade. Not the usual ER noise, not the drunk patients or the scared children, or the elderly with dementia calling for nurses who'd left hours ago. This was different. This was the sound of someone being burned alive. I dropped the coffee, ran toward the sound. My shoes squeaked on the linoleum, loud in the sudden silence between screams. Room 12. The door was closed, but I could hear thrashing inside. Something metal hitting the floor. A nurse's voice, calm but urgent. I pushed through the door. A man was in the bed, mid-30s, military haircut, lean and muscular. His hospital gown was soaked with sweat. His hands were clawing at his right leg, or where his right leg should have been, because there was nothing there. Just a bandaged stump ending below the knee, wrapped in clean white gauze. But he was screaming like his leg was on fire. "It's burning," he gasped, eyes wide and wild. "It's burning again. The fire. I can feel it." The nurse, Martinez, her name tag read, had her hands on his shoulders, trying to keep him from falling out of bed. "Sir, you need to calm down. There's no fire. You're safe. You're at St. Halsted Hospital." "My leg!" He twisted, reaching down, fingers grasping at air. "Put it out! Please, God, put it out!" I moved to the bedside, checked the monitors. Heart rate 165, blood pressure through the roof, respiratory rate in the 40s. His body was in full panic mode, flooding with adrenaline, preparing to fight or flee from a threat that didn't exist. "What's his name?" I asked Martinez. "Sergeant Dylan Foster, 28. Came in 3 days ago. IED blast in training exercise, lost his right leg below the knee. Meds, pain management protocol. Last dose of morphine was at midnight." I looked at the clock. 2:47 a.m., almost 3 hours since his last dose. But this wasn't breakthrough pain. This was something else entirely. "Sergeant Foster," I said, loud and clear. "My name is Dr. Reyes. I need you to look at me." His eyes found mine. They were gray, the color of storm clouds, and filled with absolute terror. "My leg is on fire," he said. "I can feel it burning. The metal, the shrapnel, it's heating up inside my skin. Sergeant Foster, look down. Look at your leg." I can't look. It hurts too much." "Look." He looked, and I watched his face change as his brain tried to process what his eyes were seeing. The bandaged stump, the absence, the impossible reality that the leg he could feel burning, the leg that was screaming in agony, was no longer attached to his body. "It's gone," he whispered. "Yes, but I can feel it. I can feel every nerve, every muscle, the heat, the pain. How?" His voice broke. "How can it hurt if it's not there?" And that's when I understood. This wasn't a medical emergency. This was phantom limb pain, and I had no idea how to stop it. Let me take you back 12 hours. It was a Monday, my 3rd week of residency at St. Halsted. The kind of day that starts unremarkable and ends with you questioning everything you thought you knew about medicine. I'd been assigned to the surgical floor for the week. Post-op care, wound management, the unglamorous side of medicine that doesn't make it into medical dramas. But it's important work, the work that keeps people alive after the surgeons have done their part. The surgical floor smelled like antiseptic and clean linens. The hallways were quiet in the early morning, just the soft beep of monitors and the occasional shuffle of nurses making rounds. I'd arrived at 6 a.m., grabbed my patient list from the charge nurse, and started reviewing charts. 17 patients under my care this week. Most were routine post-op, appendectomies, hernia repairs, a cholecystectomy, the kind of cases where you check vitals, change dressings, make sure there's no infection, and send people home. But one name caught my attention. Sergeant Dylan Foster, room 12. The chart was thick, detailed. Emergency admission Friday night. Transferred from Fort Riley Medical Center. The notes were clinical, precise, but I could read between the lines. Sergeant Dylan Foster had been admitted Friday night. Emergency surgery. A training accident at Fort Riley, about 2 hours from St. Halsted. An IED simulation gone wrong. The device had detonated too close, sent shrapnel tearing through his right leg below the knee. The field medics had stabilized him. The surgeons at the base hospital had tried to save the leg, but the damage was too extensive. Shattered bone, severed arteries, nerve damage beyond repair. They'd made the call. Amputation below the knee. Better to lose part of the leg than risk sepsis, compartment syndrome, death. The surgery notes describe the injury in careful detail. Multiple fragment wounds, thermal burns to the anterior compartment, compromised vascular supply. The surgeons had worked for hours trying to reconstruct the limb, but in the end, the tissue was too damaged. Necrotic. Dying. Dr. Richard Vance had done the surgery here at St. Halstead. Vance was one of the best trauma surgeons in the state. Calm. Precise. The kind of surgeon who could rebuild a human body like a master craftsman restoring a broken watch. The surgery had gone well. Clean amputation. Good blood flow to the remaining tissue. No complications. Dylan had woken up Saturday morning, groggy from anesthesia, disoriented. The first thing he'd asked was whether they'd saved his leg. The nurse had told him the truth. He'd nodded, closed his eyes, and said nothing else for 6 hours. That's what the chart said. That's what the nurses had told me during morning rounds. He's taking it hard, Martinez had said, but that's normal. Losing a limb, it's traumatic. He needs time to process. I'd nodded, made a note to check on him later. But the day had been busy. A post-op infection in room 3. A patient in room 7 whose surgical drain had clogged. An elderly woman in room 10 who kept pulling out her IV and trying to walk to the bathroom despite strict bed rest orders. The surgical floor was never as dramatic as the ER, but it had its own intensity. The constant vigilance, the attention to detail. One missed sign of infection could turn septic. One overlooked complication could mean another trip to the OR. I'd worked through lunch, subsisting on vending machine coffee and a granola bar I'd found in my coat pocket. By the time I made it to room 12, it was almost 8 p.m. Dylan was awake, sitting up in bed, staring at the wall. The room was dim. He hadn't turned on the lights, just sat there in the semi-darkness, illuminated by the glow from the monitor and the light seeping in from the hallway. "Sergeant Foster?" I'd knocked on the doorframe. "I'm Dr. Reyes. I'm part of the team taking care of you. How are you feeling?" He'd turned to look at me. His face was blank, empty. "Fine," he'd said. "Any pain?" "No." "The surgical site feels okay?" "I guess." I'd checked his vitals. Normal. Checked the bandages. Clean. No signs of infection. The surgical site looked good. Healing well. No redness. No drainage. No heat. "The nurses say you haven't eaten much today. Not hungry. You need to keep your strength up. Healing takes energy." "Sure." I'd tried to engage him. Asked about his family, his unit, his plans after recovery. Every answer was monosyllabic. Flat. Like talking to someone who'd had all the color drained out of them. His personnel file said he'd been in the Army for 8 years. Infantry, multiple deployments, decorated. The kind of soldier who'd made the military his life, and now that life had been irrevocably changed. Classic signs of depression, also normal after traumatic amputation. The literature said that up to 30% of amputees experience major depressive disorder in the first year. The loss isn't just physical, it's psychological. Identity, self-image, purpose, all of it called into question by the absence of a limb. "There's a psychiatrist on staff," I'd said. "Dr. Ellen Park. She specializes in trauma. I can have her come talk to you if..." "I'm fine," Dylan had said. "I just want to be alone." "Okay, but if you need anything, I won't." I'd left feeling uneasy, but what could I do? Force him to talk. The man had just lost his leg. Of course he was depressed. I'd made a note in his chart, recommended psych consult, requested daily check-ins, added a note about monitoring for suicidal ideation, a real risk in amputee patients, especially military personnel who'd built their entire identity around physical capability. And then I'd gone home, slept fitfully, dreamed of nothing. I'd come back Monday morning, today, ready for another unremarkable day. I had no idea that by 2:47 a.m., everything would change. "Phantom limb pain," Dr. Callahan said when I called her at 3 in the morning. I was standing outside room 12. Dylan had finally calmed down after I'd given him an emergency dose of morphine, but I could still hear him whimpering through the door. Still see the haunted look in his eyes when he'd realized his brain was lying to him. "Are you sure?" I asked. "You said he can feel his missing leg. Feel it burning. Feel specific sensations in specific places. That's textbook phantom limb syndrome. But it's only been 3 days since the amputation. Doesn't matter. Phantom pain can start immediately, or years later. Every patient is different." I rubbed my eyes, tried to process. The hallway was quiet at this hour, just the distant hum of machines and the occasional footstep of a nurse making rounds. "What causes it?" I asked. "We don't entirely know. Best theory is that the brain has a map of the body. When you lose a limb, the map doesn't update. The neurons that used to receive signals from that limb are still firing, still expecting input. When they don't get it, they misinterpret other signals as coming from the missing limb, so his brain thinks his leg is still there. Exactly. And in this case, it thinks his leg is on fire. Why fire? Callahan was quiet for a moment. What was the mechanism of injury? IED blast. Was there fire involved? I thought back to the chart, to the notes from the field medics, the detailed description of the injury. Yes, the blast ignited some accelerant nearby. Fuel from a nearby vehicle, I think. His leg was burned before the shrapnel hit. The thermal damage was part of why they couldn't save it. Then that's probably what his brain is remembering. The last sensation the leg experienced before it was destroyed. Fire, heat, pain. And now that sensation is trapped in a feedback loop, playing over and over. The neurons that used to process sensation from that leg, they're still active, still firing. But without input from the actual limb, they're pulling from memory. The most recent, most intense memory, which is burning. I felt cold. The hospital was always cold at night, but this was different. This was the chill of understanding just how cruel the human nervous system could be. How do we stop it? That's the question, isn't it? Callahan sighed. I could hear the exhaustion in her voice. She'd been on shift for 12 hours. Phantom limb pain is notoriously difficult to treat. We can try medications. Nerve blocks, physical therapy, mirror therapy sometimes works. Mirror therapy? You use a mirror to trick the brain into thinking the missing limb is still there. Create visual feedback that contradicts the pain signals. It's bizarre, but it works for some patients. About 30 to 40% see significant improvement. And if it doesn't work, then we keep trying, because the alternative is a patient in constant agony from a limb that doesn't exist. And that's a special kind of hell, Reyes, one we need to do everything we can to prevent. I looked through the window into room 12. Dylan was lying still now, eyes closed, but I could see the tension in his jaw, the way his hands gripped the sheets. Even sedated, even calm, his body was braced for pain. I'll need your help, I said. You've got it. Let's meet first thing in the morning, 7 a.m. We'll put together a treatment plan. In the meantime, keep him comfortable. Monitor him closely and document everything. If this becomes a chronic issue, we'll need detailed records for his disability claim. Disability claim? He's military, Reyes. This happened during service. The VA will be involved. They'll need comprehensive documentation to determine his benefits, his pension, his long-term care options. Make sure everything goes in the chart. I will. Good. Try to get some rest. You sound exhausted. I'm fine. That's what everyone says right before they crash. Go lie down for an hour. Dylan's stable. The nurses can call you if anything changes. She hung up. I stood there for a moment, watching Dylan through the glass, and I thought about what it must be like. To feel your body burning. To reach down to put out the flames and find nothing there. To have your brain insist that you're in agony while reality tells you the source of that agony no longer exists. A special kind of hell. Yeah, that about covered it. I thought about Callahan's advice. Rest, sleep, but I knew I wouldn't. Couldn't. Not with Dylan suffering in that room. Not with the image of his face. The terror, the confusion, the betrayal burned into my mind. So instead, I went to the residence lounge, pulled out my laptop, and started researching. I didn't sleep after the call with Dr. Callahan. I spent the rest of the night researching, reading every article I could find on phantom limb pain, the theories, the treatments, the success rates, or lack thereof. The residence lounge was quiet at this hour, just me and the glow of my laptop screen. Outside the window, the city was dark, a few scattered lights, the occasional car passing on the street below. What I found wasn't encouraging. Phantom limb syndrome affects up to 80% of amputees. For some, it's mild, occasional tingles or itches in the missing limb. Annoying but manageable. The brain's confused signals manifesting as minor sensory glitches. For others, it's debilitating. Constant pain, burning, crushing, stabbing sensations that never stop. Some patients describe it as feeling like their missing hand is clenched in a permanent fist, fingernails digging into a palm that isn't there. Others feel like their absent foot is being crushed in a vice. One case study described a woman who felt like her amputated fingers were being slowly bent backwards, joint by joint, 24 hours a day. And the worst part? Traditional pain medication barely touches it, because the pain isn't coming from damaged tissue. It's coming from confused neurons in the brain and spinal cord. You can't fix a neurological problem with morphine. The opioids might take the edge off, might help the patient sleep, but they don't address the root cause. The treatments were a mixed bag. Some patients responded to anticonvulsants like gabapentin or pregabalin. These medications work by dampening nerve excitability, essentially turning down the volume on neurons that are firing too aggressively. Success rate, about 50%. Others needed antidepressants, SNRIs like duloxetine or venlafaxine. These work by modulating neurotransmitters in the pain pathways. Success rate, about 40%. Some found relief with nerve blocks, injections that temporarily disabled the nerves in the residual limb. But these were temporary solutions. The blocks wore off, and repeated injections carried risks: infection, nerve damage, scar tissue buildup. And then there were the experimental treatments. Mirror therapy, using a mirror to create the visual illusion of a complete limb. Virtual reality, similar concept but more immersive. Transcranial magnetic stimulation, using magnetic fields to directly modulate brain activity. Spinal cord stimulators, implanted devices that sent electrical pulses to interrupt pain signals. Some worked, some didn't. There was no way to predict which patient would respond to which treatment. It was medicine at its most frustrating. Trial and error, throwing darts at a board and hoping something stuck. I found one case study that particularly resonated. A 32-year-old veteran who'd lost his arm in combat. Experienced severe phantom pain for 2 years. Nothing worked. Not medications, not nerve blocks, not therapy. He'd become suicidal. Was planning his death when a researcher contacted him about an experimental VR protocol. Within 3 months, his pain had decreased by 70%. Within 6 months, he was off all pain medications, living a normal life. But it was just one case, one success in a sea of failures. I made notes, compiled a list of potential treatments, questions for Dr. Callahan, things to discuss with Dylan, if he'd talk to me. That was the other problem. Dylan had shut down, built walls, stopped engaging, and I couldn't help him if he wouldn't let me in. By the time dawn broke, I'd filled 3 pages of notes, treatment options, questions for Dr. Callahan, things to discuss with Dylan. The sun rose slowly over the city, pink and orange spreading across the sky. It should have been beautiful, but all I could think about was Dylan, about the fire he was feeling, the leg that wasn't there. I showered in the residence locker room, changed into fresh scrubs, grabbed coffee from the cafeteria, terrible coffee, but coffee nonetheless, and headed to the surgical floor. Dylan's room was dark, curtains drawn. I knocked softly. "Sergeant Foster? It's Dr. Reyes, can I come in?" No answer. I pushed the door open. Dylan was in bed, facing the wall. His breakfast tray sat untouched on the bedside table. Scrambled eggs going cold, toast unbuttered, orange juice condensation pooling on the plastic surface. "Dylan," I said, "we need to talk." "About what?" His voice was flat. "About what happened last night. I don't want to talk about it." "I know, but we need to, because it's going to keep happening unless we address it." He didn't respond. I pulled up a chair, sat down. "What you experienced last night, the burning sensation in your missing leg, it's called phantom limb pain. It's a real medical condition. It's not in your head. You're not going crazy. Feels like I'm going crazy. I know, but you're not. Your brain is trying to make sense of conflicting information. It knows your leg is gone, but the part of your brain that controlled that leg hasn't gotten the message yet. So it's creating sensations, memories of pain, and it feels completely real, because to your nervous system, it is real." Dylan turned over, looked at me. His eyes were bloodshot, dark circles underneath. He looked like he'd aged a decade overnight. "How long does it last?" "It varies. For some people, it fades over time. For others, it's chronic. But there are treatments, things we can try to reduce the pain, maybe even eliminate it." "Like what?" "Medications, nerve blocks, physical therapy. There's something called mirror therapy that's shown promising results. I don't want drugs. I don't want to be numb all the time. These aren't like morphine. They work differently. They target the nerves specifically, help retrain your brain. And if they don't work," I hesitated. Honesty was important, but so was hope. "Then we try something else. We keep trying until we find what works for you. And if nothing works, we'll cross that bridge if we come to it. But I'm not giving up on you, Dylan. This is treatable. Difficult, yes, but treatable." He stared at me for a long moment, then looked away. "It felt so real," he said quietly. "The fire. I could feel the heat, smell my skin burning. I reached down to put it out, and his voice broke. There was nothing there, just air, and my brain couldn't understand why I couldn't touch my own leg. I can't imagine how terrifying that must have been. It's still there, right now. I can feel it. My foot, my ankle, my calf, like they're all still attached. But when I looked down, he closed his eyes. Nothing. That's the phantom sensation. The pain is one type, but some people also feel the presence of the missing limb, like it's still there, just invisible. So I'm going to spend the rest of my life feeling a leg that doesn't exist. Not necessarily. The brain is adaptable. With the right treatment, with time, the phantom sensations can fade. Your brain can learn to update its map. And until then, we manage it. We keep you comfortable. We try different approaches, and we don't give up. Dylan was quiet. Then, why do you care? The question caught me off guard. What? Why do you care? You're a doctor. You've got dozens of patients. I'm just another case, another chart. Why do you care if I'm in pain? I thought about that. About why I'd gone into medicine. About the oath I'd taken. About the man lying in this bed who'd sacrificed part of himself in service to his country and was now being tortured by his own nervous system. Because you deserve better than this, I said. You deserve to live without pain, and it's my job to help you get there. He looked at me, and something in his expression softened. Okay, he said. Okay, let's try. Dr. Callahan met me at 7 a.m. sharp. She looked tired. An overnight shift in the ER will do that, but alert, focused. She carried a thick folder under her arm. Is that all research on phantom limb pain? I asked. This? No. This is just the last 5 years of studies. The full literature would fill a library. She set the folder on the nurse's station. I've been reviewing Dylan's case. The mechanism of injury is particularly relevant. Blast trauma with burn component. That's going to complicate treatment. How so? Burns leave a specific type of nerve damage. The thermal injury can cause permanent changes to how the nerves fire. The heat doesn't just damage tissue, it alters the molecular structure of nerve fibers, changes their sensitivity, their firing patterns. Mix that with amputation and you've got a perfect storm for intractable phantom pain. Intractable as in untreatable? Intractable as in very difficult to treat. Not impossible, but we need to be realistic about expectations. This isn't going to be a quick fix. I nodded. What's the first step? We start with medications. I'm thinking gabapentin to start. It's a nerve pain medication. Works on the calcium channels in neurons. Helps reduce aberrant firing. Side effects? Dizziness, fatigue, some cognitive dulling. But it's generally well tolerated. We'll start low and titrate up. Give his system time to adjust. And if that doesn't work, then we add an antidepressant. SNRIs like duloxetine can help with nerve pain. They work on different pathways than gabapentin. We can also try a nerve block. Inject local anesthetic into the residual limb to interrupt pain signals. Sometimes resetting the system can break the pain cycle. How long until we know if something's working? Days to weeks. Nerve pain is slow to respond. We have to be patient, which I know is hard when someone's suffering. Does Dylan know this? Not yet. That's where you come in. He trusts you, Reyes. I can see it in his chart. The way he responds to you versus other staff. You've built rapport. Use that. Help him understand this is a marathon, not a sprint. I thought about my conversation with Dylan earlier. The raw vulnerability in his voice when he'd described feeling his leg burn. I'll talk to him, I said. Good. And there's something else we need to discuss. What? Psychology. Dylan needs to see Dr. Park, the psych consult you recommended. He refused. Then we need to make it non-negotiable. Phantom limb pain has a psychological component. The trauma of the amputation, the grief of loss, the fear and anxiety. All of that feeds into the pain cycle. Pain and psychology are inseparable. If we only treat the physical symptoms and ignore the mental health aspect, we're fighting with one hand tied behind our backs. He's not going to like it. He doesn't have to like it. He just has to do it. Callahan picked up the folder. I'll write the orders. You break the news. And Reyes? Yeah? This is going to be hard. For him and for you. Phantom limb patients can be challenging. The pain makes them irritable, depressed, sometimes aggressive. Don't take it personally. And don't try to be their hero, just be their doctor. I understand. She walked away. I stood there for a moment, steeling myself. Then I headed back to room 12. Dylan was awake, staring at the ceiling. Back already? He said. We need to talk about the treatment plan. He sighed. Let me guess. Pills. Among other things. I pulled up the chair. Dr. Callahan wants to start you on gabapentin. It's a medication that helps with nerve pain. Targets the specific type of pain you're experiencing. Side effects? Might make you tired, a little foggy, but it should help reduce the burning sensation. Should? There are no guarantees with phantom limb pain, but this is a good first step. What else? We'll monitor you closely, adjust the dose as needed, and if the gabapentin isn't enough, we have other options. Nerve blocks, additional medications, physical therapy. Physical therapy for a leg I don't have? It sounds counterintuitive, but yes, there are techniques, mirror therapy for instance, that can help retrain your brain, reduce the phantom sensations. Dylan was quiet, processing. What else? He asked. I hesitated. Dr. Callahan wants you to see a psychiatrist. His expression hardened. No, Dylan. I said no. I'm not crazy. I don't need a shrink. No one said you're crazy. But losing a limb is traumatic. And trauma affects how your brain processes pain. Talking to someone who specializes in that, I don't need to talk. I need my leg back. Can your shrink do that? No, but she can help you cope with the loss, help you process what happened, and that can reduce the pain. You don't know that. You're right, I don't. But I know that patients who address the psychological component of phantom pain tend to have better outcomes than those who don't. Dylan turned away. I don't want to talk about my feelings. Then don't talk about your feelings, talk about the pain, about what it's like to feel something that isn't there. Dr. Park is an expert. She's worked with dozens of amputees. She might have insights that we don't. Or she might be a waste of time. Maybe. But what if she's not? What if she has a technique or a strategy that helps? Isn't it worth trying? He didn't answer. Dylan, I'm not going to force you, but I am going to strongly recommend it. Because I want you to get better, and that means trying everything available, even the things that make you uncomfortable. Long silence. Then, fine, 1 session. If it's bullshit, I'm done. Fair enough. I made a note in his chart. Scheduled the consult with Dr. Park for that afternoon. As I was leaving, Dylan called out, Dr. Reyes. I turned. Yeah? Earlier, when I asked why you cared, you said I deserve better than this. You do. Most people don't see it that way. They see a soldier who got hurt doing his job, like it's just part of the deal. Like I signed up for it so I shouldn't complain. That's not how I see it. How do you see it? I thought about that. I see someone who's suffering, and my job is to reduce suffering. It's that simple. He nodded slowly. Thanks. I left before he could see the doubt in my eyes, because the truth was, I didn't know if I could help him. I didn't know if anything we tried would work, but I was going to give it everything I had. The gabapentin didn't work. We started Dylan on a low dose that afternoon. By evening, he was dizzy and exhausted, but the phantom pain hadn't decreased. If anything, it seemed worse. It's like someone's holding a blowtorch to my shin, he told me during evening rounds. Constant, never stops. And now I can barely keep my eyes open, but I can't sleep because the pain keeps waking me up. I increased the dose, waited, watched. By Tuesday morning, Dylan was a wreck, eyes hollow, skin pale. He'd barely slept. The phantom pain was relentless, a continuous burning that never gave him a moment's peace. This isn't working, he said. We need to give it more time. Your body needs to adjust to the medication. How much time? A few more days. I can't do a few more days. I can't. His hands clenched the sheets. It's getting worse. The burning is spreading. I can feel it in my thigh now. Like the fire is crawling up my leg, eating me from the inside out. I checked his residual limb. No signs of infection, no inflammation. The wound was healing well. Skin pink and healthy. No heat, no redness, no drainage. But Dylan's brain was convinced his leg was being consumed by flames. I'm going to talk to Dr. Callahan, I said. See about adding another medication, or trying a nerve block. Do whatever you want, just make it stop. The desperation in his voice haunted me as I left the room. I found Dr. Callahan in the ER. She was suturing a laceration on a teenager's forehead. Steady hands, precise stitches. How's Dylan? She asked without looking up. Not good. The gabapentin isn't working. The pain is worse. Worse how? He says it's spreading, up his thigh, and he can't sleep. Callahan tied off the last stitch, thanked the patient, stripped off her gloves. Let's add duloxetine, she said. SNRI. Should help with the pain and the insomnia, and I want to schedule a nerve block for tomorrow. We'll inject local anesthetic into the femoral nerve. See if we can interrupt the pain signals at the source. What about his psych eval? Dr. Park saw him yesterday. And? He shut down. Wouldn't engage. She said he's severely depressed and experiencing significant PTSD symptoms, but he refused medication, said he doesn't want anything that messes with his head. His head is already messed with. That's the problem. I know, but I can't force him. Callahan sighed. No, you can't. But you can keep trying to convince him. Because phantom pain plus depression plus PTSD is a recipe for disaster. If we don't address all three, we're not going to make progress. I'll talk to him again. Do more than talk. Light a fire under him. Because at this rate, he's going to be in agony for the rest of his life. The words hit me like a punch. Because I knew she was right. If we couldn't find something that worked, if the pain continued unchecked, Dylan would never have a normal life. He'd be trapped in a cycle of suffering with no escape, and that was unacceptable. Wednesday morning, we took Dylan to the procedure room. He was quiet during the prep, withdrawn. The pain had worn him down to nothing. Dark circles under his eyes, hands trembling slightly from exhaustion. The procedure room was cold and sterile. Bright lights overhead, metal instruments laid out on blue surgical drapes, the smell of alcohol and antiseptic. Dr. Vance, the surgeon who'd performed the amputation, came in to do the nerve block. He was in his 50s, gray at the temples, with the calm confidence of someone who'd done this procedure hundreds of times. Sergeant Foster, he said, I'm going to inject local anesthetic into the nerve that controls sensation in your leg. It's going to feel weird, pressure, maybe some tingling, but it shouldn't hurt. The goal is to give you some relief, at least temporarily. How long does it last? Dylan asked. The block itself? 4 to 6 hours? But sometimes interrupting the pain signal can have lasting effects. Reset the nervous system, so to speak. Give your brain a chance to recalibrate. And if it doesn't work, then we try something else. But let's hope it does. Vance prepped the injection site. I watched as he carefully palpated Dylan's groin, feeling for the femoral artery, the anatomical landmark that would guide him to the nerve. Deep breath, he said. The needle went in. Dylan flinched but didn't cry out. Vance injected slowly, withdrew the needle, applied pressure to prevent bleeding. Done. How do you feel? Dylan frowned. I don't know. Weird. My leg feels... He stopped. His eyes went wide. It's gone. The pain? No. My leg. The phantom sensation. I can't feel it anymore. It's like it disappeared. I felt a surge of hope. That's good, right? I don't know, it's strange. I've been feeling that leg for 3 days straight. Burning, aching, there, and now it's just nothing. Empty space. Does it hurt? Vance asked. No, but it's unsettling. That's normal. Your brain is adjusting. Give it a few minutes. We waited. Dylan kept looking down at his residual limb, then looking away, like he couldn't quite believe what he was experiencing. After 10 minutes, he said, The pain's gone. The burning. I don't feel it anymore. I wanted to celebrate. To tell him this was the breakthrough we'd been hoping for. But Vance's expression stopped me. Remember, he said quietly, this is temporary. The block will wear off. The pain might come back. Might? Dylan asked. We don't know. Every patient is different. But there's a chance it won't come back? There's always a chance. Dylan nodded. And for the first time since I'd met him, he smiled. It didn't last. By 8 p.m., the burning was back. Worse than before. Dylan's scream woke me at midnight. I'd fallen asleep in the on-call room, fully clothed, too exhausted to even take off my shoes. The sound cut through my dreams like a knife. I ran. Room 12. The door was open. 2 nurses inside, trying to restrain Dylan. He was thrashing in the bed, both hands clawing at his residual limb, nails digging into the bandages. It's worse, he was shouting. It's so much worse. The fire, it's inside the bone. I can feel it melting. I grabbed his hands, held them. Dylan, look at me. His eyes found mine, wild, terrified. Make it stop, he begged. Please, I can't do this anymore. Just cut it off. Cut off the rest of the leg. Cut higher. Maybe if you take more, the pain will stop. Dylan, that won't help. The pain isn't in your leg. It's in your brain. Then cut open my brain. I don't care. Just make it stop. He was sobbing now. Great heaving sobs that shook his whole body. I looked at the nurses. Get me lorazepam. 2 milligrams IV and call Dr. Callahan. Tell her we have a psychiatric emergency. They moved fast. The medication went in. Within minutes, Dylan's breathing slowed. His body relaxed. The panic faded from his eyes, replaced by a foggy exhaustion. I'm sorry, he mumbled. I'm sorry, it hurts so much, and I don't know how to make it stop. I know. We're going to figure this out, I promise. But even as I said it, I wasn't sure I believed it. Dr. Callahan arrived 20 minutes later. She pulled me into the hallway. "This is bad," she said. "I know. He's decompensating. The pain is breaking him, and we're running out of options. What about the spinal cord stimulator? Or the mirror therapy? Mirror therapy takes weeks, and he needs relief now. As for the stimulator, that's invasive. Surgery, implanting electrodes in his spine. It's a last resort." "Are we at last resort?" She looked through the window at Dylan. He was lying still now, sedated, but even in sleep his face was creased with pain. "We might be," she said quietly. "There has to be something else." "There is, but you're not going to like it." "What?" "Amputation revision. We go back in, remove more of the limb. Sometimes that helps. Removes damaged nerve tissue, gives the brain a cleaner endpoint." I felt sick. "You want to take more of his leg?" "I don't want to, but if the alternative is intractable pain..." "No, there has to be another way." "Then find it, because I'm out of ideas." She walked away. I stood there staring at Dylan through the glass, feeling utterly helpless. This was the part of medicine they don't prepare you for. The cases where everything you try fails, where the patient suffers, and you can't fix it no matter how hard you try. I thought about Dylan asking me earlier why I cared, and I realized I cared because I had to believe I could help, that medicine could help, that there was always an answer if you looked hard enough. But what if there wasn't? What if sometimes people just suffered, and there was nothing you could do but watch? I couldn't accept that. I wouldn't. So I went back to the library, back to the research, and I read until dawn, searching for something, anything, that we hadn't tried yet. And that's when I found it. A case study from 2018, a patient with intractable phantom limb pain. Nothing had worked, until they tried something experimental, something radical, something that just might save Dylan Foster's life. Virtual reality? Dr. Callahan stared at me like I'd lost my mind. "You want to treat phantom limb pain with virtual reality?" It was 6 a.m. I'd found her in the cafeteria, nursing coffee and reviewing charts. I'd printed out the case study. 3 pages, small font, dense medical jargon. "Just read it," I said, shoving the papers across the table. She read. I watched her expression change from skepticism to curiosity to something like hope. "This is interesting," she said finally. "It's more than interesting. It worked. Complete resolution of phantom pain in a patient who'd failed every other treatment. In one patient. One case study doesn't make a treatment protocol, but it's worth trying. What do we have to lose?" Callahan set down the papers. "Okay, walk me through it. How does it work?" "The theory is similar to mirror therapy. You use visual feedback to trick the brain, but instead of a mirror, you use VR. The patient wears a headset, sees a virtual version of their missing limb, and they can control it, move it, flex it, use it. The brain sees the limb moving normally and starts to rewrite the pain signals." That sounds like science fiction. I know, but there's actual neuroscience behind it. The brain is plastic, adaptable. If you give it the right input, it can reorganize, update its body map, and if the map updates, the phantom pain might resolve. Might. It's better than nothing. Better than taking more of his leg. Callahan was quiet for a moment. Then, "Do we even have VR equipment?" "The hospital has a VR setup in the physical therapy department. They use it for stroke rehabilitation. I already talked to the PT director. She says we can borrow it." "You've been busy." I couldn't sleep. Neither could Dylan, I'm guessing. I shook my head. He had another episode around 4 a.m. The nurses had to sedate him again. Callahan rubbed her eyes. "Okay, let's try it. But we need to manage expectations. This is experimental. It might not work. And even if it does, it might take time. I'll talk to Dylan. Make sure he understands. And Reyes, if this doesn't work, if nothing works, we need to have a serious conversation about long-term management, pain clinics, opioid contracts, maybe even palliative care consult." The words hit me like ice water. Palliative care, end-of-life planning, for a 28-year-old man. "It's not going to come to that," I said. "I hope you're right." Dylan was awake when I entered his room at 8 a.m. He looked like he'd aged 10 years in 3 days. Hollow cheeks, sunken eyes, the kind of exhaustion that comes from unrelenting pain. "More pills?" he asked. "No, something different." I explained the VR therapy. He listened without interrupting. When I finished, he said, "You want me to wear a headset and play video games? It's not a game. It's a therapeutic intervention. There's actual science. I don't care about the science. Will it work? I don't know, but it worked for at least one other patient, and we're running out of options. He looked at his residual limb. The pain is spreading again. I can feel it in my hip now, my lower back. It's like the fire is crawling up my spine. That's why we need to try this. If we can interrupt the pain signal, retrain your brain, maybe we can stop the progression. And if it doesn't work? I hesitated. Honesty versus hope. Then we try something else, like cutting off more of my leg. That's one option, but I'd like to avoid it if possible. So would I. He closed his eyes. Okay, let's try your VR thing. What do I have to lose? Nothing, and potentially a lot to gain. When do we start? This afternoon. I need to coordinate with physical therapy, set up the equipment, but I'll be back at 2 p.m. I'll be here, not like I can go anywhere. The bitterness in his voice stung, but I understood it. Dylan had been an active, athletic soldier. Now he was trapped in a hospital bed at war with his own nervous system. I left to make arrangements. The PT department was on the second floor, bright, open, full of exercise equipment and parallel bars and patients working to rebuild their bodies. I found Sarah Chen, the PT director, in her office. Dr. Reyes, she said, I pulled the VR system like you asked. It's charged and ready to go. Thank you. Can you walk me through how it works? She led me to a storage room. The VR system was surprisingly compact. A headset, 2 handheld controllers, a laptop for processing. It's designed for stroke patients, Sarah explained. Helps them relearn motor skills. They wear the headset, see a virtual version of their body, and practice movements. The visual feedback helps the brain reconnect with paralyzed limbs. Can we modify it for an amputee? Theoretically, yes. We'd need to create a virtual limb where the missing limb should be, and program it to respond to the patient's movements, or attempted movements. How long would that take? A few hours, maybe less if the software is flexible. She paused. But Dr. Reyes, I have to ask, is there any evidence this will work? One case study. That's it? That's it. And your patient understands this is experimental? He does. She nodded slowly. Okay, give me until noon. I'll set it up. Thank you. I spent the rest of the morning with Dylan, checking his vitals, adjusting his medications, trying to keep him comfortable. At noon, Sarah called. It's ready. Dylan and I went down to PT. He was in a wheelchair, hospital policy, even though he insisted he could hop on his one good leg. The VR system was set up in a private room, quiet, dimmed lights. Sergeant Foster, Sarah said. I'm Sarah Chen. I'm going to walk you through this. She explained how the system worked. Dylan would wear the headset, see a virtual version of himself, including his missing leg. The leg would be represented as a ghostly outline, semi-transparent. You'll be able to move it, Sarah said. Not physically, obviously, but mentally. Think about flexing your ankle, bending your knee, and the virtual leg will respond. How? The system reads muscle activity in your residual limb. Even though the leg is gone, when you try to move it, your muscles still contract slightly. The sensors pick up those contractions and translate them into movement in the VR environment. Dylan frowned. That actually works? For stroke patients, yes. We'll find out if it works for you. He put on the headset. I watched his face, watched his expression change from skepticism to surprise to something like wonder. I can see it, he said softly. My leg. It's there. It looks real. Try moving it, Sarah instructed. Dylan's face scrunched in concentration. In the VR world, I could see it on the monitor. His virtual leg flexed. The ankle rotated. The toes wiggled. Oh my God, Dylan breathed. I can move it. I'm moving my leg. How does it feel? I asked. Strange. Really strange. But he paused. The burning. It's less. Not gone, but less. I felt a spark of hope. Keep going. Keep moving the leg. For the next 30 minutes, Dylan worked with the VR system, moving his phantom leg, flexing, extending, walking in place in the virtual world. And slowly, gradually, the pain decreased. It's working, he said, voice full of awe. It's actually working. The fire it's cooling down, like someone's pouring water on it. Sarah and I exchanged glances, cautious optimism. Let's keep the session going, I said. See how far we can push it. We worked for another hour. By the end, Dylan was exhausted, but the phantom pain had decreased by at least half. This is incredible, he said, removing the headset. How is this possible? Your brain was stuck in a pain loop, I explained, sending fire signals to a leg that wasn't there. But when you saw the leg moving normally in VR, When your brain got visual feedback that contradicted the pain signals, it started to rewrite the narrative, update the map. So the pain is gone? For now. But it might come back. The brain needs repeated exposure, multiple sessions. We need to retrain it completely. How many sessions? I don't know, but we'll do as many as it takes. Dylan nodded, and for the first time in days he looked hopeful. Thank you, he said. Seriously, thank you. Don't thank me yet. We've got a long road ahead. I know, but this is the first time I've felt like maybe I can actually get through this. I smiled. You can. We'll make sure of it. The pain came back that night, not as intense as before, but enough to wake Dylan, enough to remind him that the relief was temporary. I increased his VR sessions to twice daily, morning and evening. Each session, the pain decreased, but each night it crept back. It was frustrating. 2 steps forward, 1 step back. But Dylan didn't give up. He showed up for every session, worked hard, pushed through the discomfort of wearing the headset, the weirdness of seeing a leg that wasn't there, the cognitive dissonance of moving something with his mind. By the end of the week, the phantom pain had decreased by about 60%. Still there, still uncomfortable, but manageable. It's like turning down the volume, Dylan told me during rounds. It's not silent, but it's not screaming anymore either. That's progress. Yeah, but I want it gone, completely gone. That might not be realistic. Some level of phantom sensation is normal. The goal is to get it to a point where it doesn't interfere with your life. And what if it never gets there? Then we keep trying. Add other modalities. Physical therapy, occupational therapy, maybe even a prosthetic. A prosthetic? For some amputees, wearing a prosthetic reduces phantom pain, gives the brain something physical to anchor to. Might be worth exploring. Dylan was quiet. Then, I'm scared. Of what? Of this being my life. Of always being in pain. Always being broken. You're not broken, Dylan. I feel broken. I know. But you're healing. It's just slow and non-linear, but you're getting better. I promise. He wanted to believe me. I could see it in his eyes, but he was scared. And so was I. Because what if this was as good as it got? What if 60% reduction was the ceiling? Could Dylan live with that? Could I live with knowing I couldn't do more? Dr. Park, the psychiatrist, caught me in the hallway on Thursday afternoon. Dr. Reyes, I need to talk to you about Dylan Foster. Is something wrong? That depends on your perspective. He's finally opening up, talking about the accident, about what happened. That's good, right? Yes and no. The trauma runs deeper than I initially thought. He's carrying a lot of guilt. Guilt? About what? About being the only survivor. I frowned. The report said it was a training accident. 1 casualty. Him. The 1 casualty was the loss of his leg. But there were other soldiers nearby when the IED detonated. They weren't physically injured. But Dylan feels responsible. For what? For the explosion. Apparently, he was the one who set up the training scenario, placed the simulated IED, calculated the safe distance. But something went wrong. The device was more powerful than expected, detonated closer than planned. Dylan took the brunt of the blast, but the shrapnel could have hit someone else, could have killed someone, but it didn't. Doesn't matter. In his mind, he put his unit at risk, made a mistake that cost him his leg and could have cost someone their life. He's consumed by that. I thought about Dylan, about the flatness in his voice when I'd first met him, the walls he'd built. How do we help him process that? Time, therapy, and honestly, addressing the phantom pain is part of it. As long as he's in constant physical agony, he can't do the deeper emotional work. It's like trying to rebuild a house while it's still on fire. So the VR therapy is essential, not just for pain management, but for his mental health. He needs relief so he can start healing, really healing. I nodded. I'll make sure we keep the sessions going. Good. And Dr. Reyes, you're doing good work here. Dylan's lucky to have you. I'm just doing my job. No, you're going above and beyond. Don't downplay that. She walked away. I stood there, thinking about what she'd said. Dylan was carrying the weight of guilt on top of everything else. The phantom pain was bad enough, but add survivor's guilt, PTSD, depression. No wonder he'd tried to shut down. I found Dylan in his room, working with the VR system. Sarah had set it up so he could do sessions independently. How's it going? I asked. He removed the headset. Better. The pain is down to maybe a 4 out of 10 today. That's the lowest it's been. That's great. Yeah. He set the headset aside. Dr. Park says you know about the accident. She told me there was guilt. Didn't give details. It was my fault. The explosion. I miscalculated, was too confident, and I paid the price. You made a mistake. That doesn't make it your fault, doesn't it? No, accidents happen, equipment malfunctions. Variables change, you can't control everything. I should have been more careful. Maybe, but beating yourself up won't change what happened. It'll just make the healing harder. He was quiet. Dylan, you survived. That's what matters. And now you get to decide what comes next. You can let the guilt and the pain define you, or you can choose to move forward. Easy for you to say. You're right, it is easy for me to say. Because I'm not the one lying in that bed. I'm not the one in pain. But I am the one who's watching you fight. And I see how strong you are, how hard you're working. Don't throw that away because you think you deserve to suffer. What if I do? Deserve to suffer? Yeah, you don't. No one does. And especially not for an accident. He looked at me. You really believe that? I do. I wish I did. Then let me believe it for both of us. Until you're ready. He smiled. Just a little. But it was there. Okay, he said. Okay. Over the next 2 weeks, Dylan improved. Slowly, incrementally, but steadily. The VR sessions continued, twice daily, sometimes 3 times if the pain flared, and each session, his brain learned a little more. The phantom leg became less of a source of agony and more of a ghost, still present, still noticeable, but not debilitating. By week 3, Dylan was sleeping through the night. No more midnight screams, no more emergency sedation. By week 4, he was eating normally, regaining the weight he'd lost. And by week 5, he was ready to start physical therapy. Real physical therapy. Learning to use crutches, preparing for a prosthetic. I never thought I'd be excited about a fake leg, he said during one of our check-ins. But here I am. How's the pain? It's there. Probably always will be. But it's background noise now. A 2 or 3 out of 10. I can live with that. And the guilt? Still working on it. Dr. Park is helping. I'm starting to see that maybe I'm allowed to forgive myself. You are? Yeah, I'm starting to believe that. I felt a swell of pride. This was what medicine was supposed to be. Not just treating symptoms, but helping people reclaim their lives. When do you think you'll be discharged? I asked. Next week, maybe. Dr. Vance says the surgical site is healed. I'm stable on my meds, and I've got outpatient PT lined up. What about the VR system? Sarah's working on getting me a home setup, loaner equipment from the hospital, so I can keep doing sessions. That's great. Yeah. He paused. Dr. Reyes, I just want to say thank you for not giving up on me, for trying something crazy like VR therapy, for seeing me as a person and not just a patient. That's my job. No, your job is to treat my symptoms. You went beyond that, and I won't forget it. I didn't know what to say, so I just nodded. You're going to do great things, Dylan said. Seriously, don't let this place beat you down. Don't lose that thing that makes you care. I'll try. Do more than try, because patients like me, we need doctors like you. Dylan left St. Halstead on a Tuesday morning. I wasn't working that day. I'd finally gotten a day off, but I came in anyway to see him off. He was in the lobby, sitting in a wheelchair per hospital policy, crutches resting against his lap. He'd been fitted with a temporary prosthetic socket, not the full leg yet, but a protective covering for his residual limb. His duffel bag sat beside him, packed with clothes and medications, and the VR headset Sarah had loaned him. Ready? I asked. As I'll ever be. His ride pulled up. An older couple. His parents, I guessed. They got out of the car, faces full of relief and worry in equal measure. Dylan's mother rushed to him, hugged him tight. His father hung back, jaw clenched, eyes suspiciously bright. We're taking him home, his mother said to me. Thank you for everything. He did the hard work, I said. I just provided the tools. Don't listen to him, Dylan said. He saved my life. I didn't. Yes, you did. Dylan looked at me. I was drowning, and you threw me a lifeline. That's not nothing. I helped him into the car, made sure his crutches and bag were secure, gave his mother instructions for follow-up appointments, and then they were gone. I stood in the parking lot, watching the car disappear down the road, and felt a mix of pride and melancholy. Pride because Dylan was going to be okay. He had a long road ahead. Physical therapy, prosthetic fitting, ongoing pain management, continued work with Dr. Park. But he was going to make it. Melancholy because I knew not every patient would have this outcome. Not every case would end with progress and hope and discharge. Some patients would suffer no matter what I did, and I'd have to learn to live with that. 6 months later, I got an email from dfosteroemail.com. Subject, update Dr. Reyes. I hope this email finds you well. I wanted to reach out and let you know how I'm doing. I've been home for 6 months now. Got fitted for my prosthetic in month 2. It took some getting used to. Feels weird to walk on something that isn't really part of you, but it's getting better. I can walk without crutches now. Even jogged a little last week. Felt amazing. The phantom pain is still there. Probably always will be, but it's manageable. I do the VR sessions a few times a week. Keep my brain in check. Some days are harder than others, but most days, I'm okay. I'm back at work. Desk job for now. The Army is figuring out where I fit in the new normal. Training new recruits, passing on what I've learned. It's different from what I used to do, but it's meaningful. I'm useful, contributing. That matters. Dr. Park and I are still working together. Turns out you were right. I had a lot of stuff to unpack. The guilt, the loss, the fear, the anger at my body for betraying me. But I'm getting there. Learning that it's okay to be broken and healing at the same time. I wanted to say thank you. Again, I know I said it when I left, but I don't think you understood how much you helped. You didn't just treat my pain. You saw me, really saw me. When I was at my lowest, when I wanted to give up, you refused to let me. And that made all the difference. I hope you're still at St. Halstead, still fighting for patients like me. The world needs more doctors like you. Doctors who don't just treat symptoms but actually give a damn about the person suffering. Stay strong, and remember, you're making a difference. Even when it doesn't feel like it. Dylan P.S. I'm running a 5K next month, fundraiser for veteran amputees. If you're free, I'd love for you to be there. Let me know. I read the email 3 times. Then I saved it in a folder labeled Why I Do This. Because some days residency is brutal. The hours are long, the cases are hard, the failures outnumber the successes. But then you get an email like this, from a patient who was drowning and found their way back to shore. And you remember, this is why. This is why you chose medicine. This is why you keep going. The next morning, I was back in the ER. Same fluorescent lights, same smell of disinfectant and coffee, same rhythm of monitors beeping in the distance. But I felt different, lighter, more certain. Dr. Callahan found me at the nurse's station. Good to have you back, Reyes. Got a case for you. Room 7, motorcycle accident, possible femur fracture. On it. As I walked toward room 7, I thought about Dylan, about the phantom leg that burned and burned until we found a way to make it stop, about the brain's remarkable ability to heal, to adapt, to rewrite its own story. And I thought about the other patients I'd see, the ones I'd help, the ones I'd save. This was the job, this was the calling, and I was exactly where I was supposed to be. Sometimes the pain we feel comes from things that are no longer there, memories that burn, losses that ache, ghosts that haunt. But the brain is adaptable, resilient. Given the right tools, the right support, it can heal. It can learn to let go of what's gone. It can update its map and find peace in the present instead of suffering in the past. That's the real miracle of medicine. Not just healing bodies, but helping people reclaim their lives, one painful step at a time. Dylan taught me that phantom pain isn't just about missing limbs. It's about all the things we've lost and can't let go of, the people who are gone, the futures that won't happen, the versions of ourselves that no longer exist. We all carry phantom pain, but we don't have to carry it alone. And with the right help, the right tools, the right persistence, we can learn to feel whole again, even when we're not.